started. So yeah, maybe I will start with introducing you. So we have the honor to have at this month's seminar, Karina Maya Lopera, and she's a Colombian radiologist currently based in Abu Dhabi, as we already heard. And she has extensive training and clinical experience in diagnostic radiology and also pediatric imaging. And she completed her diagnostic radiology residency at Beth Israel Diaconus Medical Center at Harvard Medical School, and she has held positions in both the United States and Colombia, including research and teaching roles, leading institutions such as the Children's Hospital of Philadelphia and Clínica Soma in Medellin. So Dr. Maya Lopera has also published a lot of papers with peer-reviewed articles in pediatric radiology and MRI, and also, of course, has presented her work at various conferences. Yeah, and she's also an active member of professional committees dedicated in diversity, equity, and wellness. So her talk today will be on Legwork imaging guide to common lower limb injury. Sorry. And yeah, we are happy to hear you talk. And later there will be some time for questions and discussions. So please write your questions in the chat or raise your hands so that we can unmute you to ask also any questions directly. So with that, I would like to hand it over to you, Carolina. Thank you very much.
Nice. Thank you, Eva. That was a very nice introduction. So let's start. I try to do something that should be useful and also pretty basic. And it's basically whatever is more common, the more common lower limb injuries. So hopefully it's easy to follow. So I don't have any conflict of interest. I don't tend to put that slide in there. I really don't have any. So I wanted to somewhat introduce the whole topic and like organize it. So we're going to start with some normal variants that are going to be mimics to injuries. We're going to discuss the top fractures, some dislocations. We of course have to talk about Salter-Harris classification, not only because it's very important in kids, but also because I kind of like have some fondness of it. And then we're going to end up with the most missed fractures and how we can try to avoid getting into it. So let's start with some mimics. Of course, we're talking about mimics. We're mainly thinking about mimics of fractures. It's hard to mimic dislocation. It's hard to mimic tendinous injury, but fractures do tend to get some normal variants that can pose as them. So we could see physes, we could see Harris lines, we could see some vascular channels, and we're going to go through some of them so that we are more familiar with them, and hopefully it will help us not to get into this trick of nature. So physes, yes, it sounds very obvious, like you should know that there are physes, especially in kids. However, there are some oblique physes that will make you think twice if you're not looking through a fracture. So you basically want to think of physes whenever they're in the expected location. You may see jagged linear lucencies. However, their margins are still going to be smooth, and that they tend to be bilateral and symmetric. So as any radiologist will tell you, we definitely use the contralateral side every time because it's our main point of reference, especially when we have limbs. Usually there should be two of them. So definitely bilateral and symmetric, and in the expected location, let's think of physes. Now, if we go to sesamoids, in this case, for example, we see here around the base of the first toe, we see this bone, and it looks like there's a lucency in the middle of it. And it's like, okay, well, maybe the patient has some pain in this area. Could it be a fracture? But then we see that the borders are pretty smooth. There are no acute angles. Looks pretty well corticated. And if we look further and in a different view, which is also something that we rely heavily on, we'll see that we are actually seeing as a multipartite hallux sesamoid, which is a pretty common finding. Now, if we go a little bit further, now we have these Harris lines, and Harris lines are basically growth arrest, resumption lines. So whenever kind of like the bone is growing and it stops and then continues to grow, sometimes it can form these alternating transverse rings of sclerosis. So we're seeing these white lines. The main clue that this is not per se an injury is that they tend to be very parallel. They tend to be bilateral. They're very close to the metaphysis of the long bones. So you should be thinking about these things when you see this. Like, it's very well organized. You don't tend to have injuries that look like this. They do have, though, some differential diagnoses that include rickets, the use of biphosphonates, and previous treatments for leukemia, but that you probably would know beforehand. Now, there are also some mimics like failure of fusion. You mainly see this in vertebral bodies, so that's why we're seeing some vertebral bodies here, even though we're talking about lower limb injuries. I just wanted kind of like to show you that in some ring-like structure, like a vertebral body, you could have these lines. It's a lucency, right? Like, you wouldn't be wrong if you said, yeah, there is a lucency in this posterior process. However, it is very well corticated. We're not seeing any like acute angles. We're seeing that in both sides it looks smooth. And this is what we call failure of fusion. Now, one that is very, very common, and a lot of residents kind of like get tricked by it, are the vascular channels or the nutrient foramina. And this, you see them like straight linear lucencies. So if you're very thorough and you're looking for fractures and you go through a long bone, and in the long bone you see like this very, very subtle break in the cortex, you're like, okay, could that be a fracture? And then if you look at both sides of this lucency, these borders are pretty smooth. It is very well corticated and it meets the medullary cavity. So this is just a vessel that is going through and not a fracture. And it's very common in long bones and vertebrae. So just take that into account. Now, ossicles, they are their nature's joke in for radiologists. They just put as ossicles in many different locations. This is a very nice diagram that you can find in Radiopedia, which is a really great resource. And many times you have someone with ankle pain, like one side of the ankle is very painful, and you're like looking for fractures, and then you get to see this and you're like, okay, could that be a fracture? Because you see fractures that are can look like this, avulsion fractures especially. And in this case, if you look at it, which is kind of like somewhat what I've been discussing over and over again, is that these ossicles and these bones that tend to mimic fractures, they're actually very smooth. They're pretty well corticated. You don't see any jagged lines. You don't see any acute angles. They're usually near the joints, and they're very, very common in the feet and ankles. So that's something that we should definitely take into account when we're looking for fractures in these areas. Oh, wait, hold it. Let's go back a little bit. Now, those are some of the mimics. Of course, there are plenty others, but I think these are the most common. Now, let's dive deep into injuries. I wanted to organize it a little bit as I would go through any imaging of a patient. So some sort of order. So we're going to go from the hip to the toes. In this case, we're going to start then with hip fractures. And in order to to talk about hip fractures, we definitely need to mention a little bit the capsular attachment of the hip, because this is a joint that has a particular capsular attachment. It's not, the capsule doesn't attach where the joint kind of ends. So when the femoral head kind of like meets the acetabulum, it actually goes all the way to the intertrochanteric, so greater trochanter, lesser trochanter. It goes all the way to the intertrochanteric region, and it has the very important role of covering this very particular vascular process that is happening here in the head of the femur. It's this is what we call reverse vascularization, in which the medial circumflex and the lateral circumflex, they form this sort of plexus, and it goes from the femoral neck towards the head. There is also a little bit of supply through the foveal artery. However, most of the supply to the femoral head is actually through this plexus. So if anything happens in this region, which is actually the region most common for fractures, like the femoral neck, then there is a high chance of a vascular necrosis of the femoral head if anything happens here. And this is where the capsule kind of like comes and attach all the way in the intertrochanteric region. Now, I wanted to show you, I'm not going to show a lot of MRI or CT in this talk, just because we're talking about the most common and kind of like more emergent setting. So we usually just do CTs and MRIs like a second step into the evaluation of this injury. So we're going to be very, very heavy on X-rays. But I did wanted to show you this MRI in which we can actually depict the capsule going all the way to the intertrochanteric region. Like it doesn't stop here where the femoral head ends and where it meets the acetabulum. It goes all the way to the intertrochanteric region. Now, again, why was it so important to talk about the capsule of the femoral head? Well, the thing is, with that capsular attachment, we can classify these fractures into extracapsular fractures. So this will happen outside of the capsule, subtrochanteric, when they are like within 5 centimeters of the intertrochanteric region and the intertrochanteric fractures. And then we have intracapsular fractures that they could be capital, so capital transcervical, base cervical. Some people, I mean, there are capital fractures, but they're hard to see. The most common would be the transcervical, and all of these are intracapsular fractures. And within the description of any of these studies, whenever we're doing the report of it, we definitely need to include this particular detail. This is going to help the surgeons later on decide what management they're going to go for. So here, aside from the location of the fracture, we also want to talk about angulation and dislocation. So this Garden classification is actually a very straightforward, simple classification in which he describes as a type 1 femoral head fracture as incomplete fracture, non-displaced. The type 2 is a minimally displaced, sometimes impacted fracture. And then we have the type 3 and type 4. They're both displaced, of course, different degrees of displacement. And these actually are the type of injuries that would tell the surgeon, you know, you probably should think of taking this head off, because the chances of a vascular necrosis are actually pretty high. So in this case, I wanted to go dramatic and show things that everyone could actually see in this kind of screens. We have a subtrochanteric fracture and an intertrochanteric fracture. This is actually a comminuted fracture of the lesser trochanter that is displaced. Later on, we're going to see but what tendinous attachment. And both of these fractures are extracapsular fractures. And whenever these are there under the ideal circumstances, then the surgeons usually tend to go for fixation with these dynamic screws. Dynamics because this part of the screw actually moves with the movement of the hip. Sometimes they also put this fixation screws as well to avoid any rotation within the joint itself. But they are mainly preserving the patient's own femoral head. So this is what they tend to do with extracapsular fractures. Now we have a base cervical fracture, a transcervical fracture, and a subcapital fracture. They're all part of the intracapsular fractures of the femur, the proximal femur. And whenever we see this type of fractures, we discuss with the surgeon, we tell them that is an intertrochanteric fracture, that it is an intracapsular fracture. We tell them this one is somewhat displaced, probably a Carden type 3. This one might be a Carden type 2. This looks a little bit more like a 3.5. There's no 3.5, but it's somewhat displaced. And in these cases, they typically go with a hemi-arthroplasty. Hemi, just half of the joint is replaced, because if you check this, the acetabulum itself is actually still native. And this definitely changes the management. So you want to give all the details possible in the report, because whatever we are describing and the findings that we are relaying to our colleagues are going to define the management. Now let's go further down. If I'm going too fast, please let me know. Now we're in the knee. I wanted to start with the finding of a joint effusion, which is probably one of the easiest and most common findings that we can have. So a joint effusion in the knee, you were going to see displacement of the fat pad. We shouldn't have this kind of shadow around here. The fat pad should be closer to the bone. Same thing under the patella. This is the patella. Same thing under the patella. We shouldn't have this effusion over here. And this is what an effusion looks like in a CT. This is an axial view of the effusion. I wanted to show you the bursa. There is some fluid kind of like filling in there. This is how you see it on the X-ray. This is a lateral view of the knee. This is the X-ray, and this opacity is what you see, and it displaces this fat pad. So you should have a brighter, a little bit blacker line around here like this. And this is something that is getting in between this fat. And this is how you would see it on MRI. You see there's some fluid, which is bright in this MRI sequence, and it is displacing the fat that should be much more closer to the bone. So that is a joint effusion. Now, I don't know if you guys noticed that in the image I showed you before, there was this very straight line, and it looks a little bit weird if you don't have the context that this was an image that was actually taken with a horizontal beam. And why is it important in this case? This case is a particular effusion in which is not just a simple effusion. This is called lipohemarthrosis. And it's the kind of effusion that has to make you think of an intra-articular fracture. Why? Because whenever we see this, it means there are two different type of densities within this effusion. And in this case, we have fat and we have fluid within this effusion. We have fat and we have fluid. This is MRI, so fluid is bright. The fat is a little bit darker. It's not as dark as cortical bone, but it's a little bit darker than fluid. And this is the CT. You see the fat fluid level over here, fat fluid level over here. And intra-articular bone fracture, why? So you see here, there is this pretty gnarly fracture of the tibia. And whenever we have fat in this type of effusions, it means some of the bone marrow fat is escaping and is getting into this effusion. This effusion most likely also has some blood products. We see here that it's not just 2 densities, it's a little bit like 3 densities. So some blood products, a little bit of articular or joint fluid. So we have a little bit of everything. So the horizontal beam, very useful for this kind of things. So fat kind of like floats upwards, then fluid then will remain down, and you get these fat fluid levels. Now, another type of injury, it is a common type of injury. However, this type of images are not at all common. Why? Because we usually don't get the patient coming at us still with the patella on the side. Is actually very rare. Usually someone on the field, or if it's a chronic patellar dislocator, which happens in some adolescents, especially girls with some trochial dysplasia, the patella itself kind of like is going to go back to its place. So these are very hard to get images. Actually, it's very hard to see it in this state. But I'm trying to show you patellar dislocation. The most common site is the lateral aspect of the patella. You know, it is the lateral aspect because the fibula is on the side of the lateral aspect of the knee joint. And what happens in this case is that the medial ligamentous complex gets torn or at least injured. The patella goes all the way to the lateral aspect of the femoral condyle. It can cause what we call kissing contusion. So there is a contusion in the medial aspect of the patella and the lateral femoral condyle because they knock each other out. So the patella comes all the way to the lateral aspect. It knocks the femoral condyle and turns back into its trochlear groove. There is a predisposition to patellar dislocation whenever the trochlea is very shallow, which would be a trochlear dysplasia, but it can also be a traumatic injury. Now, we're not only talking about dislocation, we're also talking about patellar fracture. So it's very common to see this type of fracture in the patella. The patella is kind of like hold on by 2 different and opposing tendons. So we have the biceps, the quadriceps tendon, sorry, not the biceps, the quadriceps tendon and the patellar tendon doing like opposite forces in the patella. So they split the patella. Once the patella fractures, they split the patella, as you see here. See here as well, we had this case in which there was direct trauma to the patella and it kind of like split this way. The quadriceps tendon is pulling it upwards while the patellar tendon is pulling it downwards. And this is the kind of fixation that our orthopedic surgeons colleague would go for. There's also this type of fixation in which there is this wire that goes through it. So it's almost kind of like locking in a gem into a ring. So this is the kind of thing that we would see in the postoperative period in these patients. Now, we're talking about knee injuries, right? If we see this type of lucency, if we see this type of lucency in this frontal view, you may be inclined to think that this is a patellar fracture. However, we still have mimics. We still have mimics around. In this case, we have a bipartite patella, which is not uncommon. It's a somewhat common finding. And the majority of cases, you're going to see that in the superior lateral aspect. We don't say always, we don't have an always in radiology, but this would be the majority of cases. So kind of like have this into account. Now let's go further down. Let's go to the ankle. Very, very common site of injury. And being a very common site of injury, it's very important to really assess thoroughly and meticulously this joint. For that, we have, of course, the standard views of radiograph. We have the frontal, we have the lateral. And in the ankle, we have this special view that is called the that is called the ankle mortise. In the ankle mortise, what we do is we turn the foot somewhat in internal rotation about 15 degrees, and that way the fibula and the distal tibia are somewhat in the same plane. Otherwise, the fibula would be posterior, a little bit posterior to the tibia or the medial malleolus. So in this case, both malleoli are in the same plane, and you're able to see the fibulocrural space and all of this joint space much, much better. So once we have that in place, we're also able to assess if there is any injury, especially of the distal fibula. These are all distal fibular fractures. And for distal fibular fractures, sorry, my bad. For distal fibular fractures, we have the Weber classification. So in the Weber classification, we're mainly assessing if the fracture affects or not the syndesmosis between the tibia and the fibula, the distal syndesmosis. So in Weber type A, we have a fracture that is distal to the syndesmosis. There is no disruption to the syndesmosis. And if you can see here, there is a fracture, yes, but the mortise is actually preserved. In this Weber type B, we have a spiral fracture of the distal fibula. It goes through where the syndesmosis should be. It's very probable that there is disruption of the syndesmosis. However, it's not readily apparent. We still have like some congruence of these lines here, and the mortise still looks somewhat congruent. And in the Weber type C, it is very apparent. It's very evident that there is disruption of the syndesmosis. Here we have again a spiral fracture of the distal fibula. There is disruption of the syndesmosis with widening of the syndesmosis and with loss of this congruence of the ankle mortise. Now we have all different kinds and what we would call combos of fractures in the ankle. Again, it's a very common site of injury. I wanted to show you this would be a Weber type C fracture of the distal fibula. So distal fibula, or what we would call the lateral malleolus here. There is also a fracture of the medial malleolus in what would constitute a bimalleolar fracture. Now, it is also very, very important to assess the lateral view of the ankle, especially once we already recognize that there are bimalleolar fractures, because the posterior aspect of the tibia, of the distal tibia, is what we call the posterior malleolus. So now we have a fracture through the medial malleolus, the lateral malleolus, and the posterior malleolus in what we will call the trimalleolar fracture. These are high impact, high force fractures, and we need to also assess other areas as well whenever this happens. Now, this is a very special way of showing the importance, the mortise view. So here we have the mortise view. We see that there is definitely some dislocation here, and we don't have any congruence. We have a step off of the line here. So there is widening of the syndesmosis here. There is lack of congruence or a step off in the view of the ankle mortise in this area. This is the fibulocrural space. And however, we're not seeing any particular fracture. And this is where we cannot kind of just say, well, probably it was nothing or just a dislocation and that's it. We need to assess the more proximal bones, because this tends to, the tibia and fibula tend to form somewhat like a ring structure. So if you think of a lifesaver and I ask you to break it, you are going to break it at least in two parts. It's very hard to just do it in one. And lo and behold, more proximal to this type of injury, we see this spiral fracture of the more proximal fibula. Here you can see it a little bit better on the lateral view. Spiral fracture of the more proximal fibula. This is what we call a mesonerve lesion. Somewhat easy to say, very, very difficult to spell. Now we went through the hip, the knee, and the ankle. These are the most common injuries. Of course, we're talking about plenty other injuries around, things that you would assess with MRI, ACL, PCL, menisci, all of these things. We would see them much better with MRI or at least with a CT, but we're trying to like really assess fast and hard with radiographs what we're doing here today. So now let's go to kids, because you also are going to have plenty of kids coming over due to sports injuries, recreational injuries, some pain whatsoever that cannot be explained. And in kids, we have the Salter-Harris classification for fractures because they still have open physes. So whoever has open physes, we're going to use the Salter-Harris fracture classification whenever we have any fracture that is close or affecting the physes. So I like this cartoon by a comic for Jimenez. I can like tend to follow him. It's very didactic, and I like how he shows the different Salter-Harris fractures. So he's mainly saying that the type 1 is a fracture that goes through the growth plate. So you just see a lucency through it. The type 2, which is actually the most common, it goes through the growth plate and the metaphysis. So you would say Salter is kind of like slit, A for above, L for lower, type 3, through the growth plate and the epiphysis. So above and lower, SAL, S-A-L. Third is through, so type 4, through all through elements, and R for ram or a crush injury of the growth plate. There are some who don't necessarily believe it actually exists. It's very rare, but it's still there in the classification. So there you go. So I wanted to mainly show you the most common. So we have here a fracture through the growth plate and exiting through the metaphysis. Again, growth plate metaphysis with some dislocation. So this is the distal tibia, this is the distal femur. And these are actually Salter-Harris type 2. I also wanted to show you that it's not only in these big joints, we also have Salter-Harris fractures in the smaller joints. And I think for the sake of the dynamic, I'm just going to say it. I was going to see if anybody could find it. It's very subtle. I wanted to trick you, maybe see if you were paying attention. This is a fracture in the proximal phalanx of the fifth digit. And here we see the fracture is going through the physis and extending through the metaphysis. Now, in this case, we have a fracture of the proximal phalanx of the first toe. And in this case, we have still a Salter-Harris type 2, that it goes through the growth plate and exits through the metaphysis, but we also have a Salter-Harris type 3, in which it goes through the growth plate and goes to the epiphysis. Here, similarly, we have a fracture that goes through the growth plate and exits the epiphysis. However, this is a particular and very special type of fracture of the distal tibia in that is called Tilo fracture. And it's a Tilo fracture, and it tends to happen, it only happens in adolescence, in which the more medial aspect of the physis has already closed. So they're old enough so that this part of the physis is already closed. However, this one remains open, and at the time of trauma, there is a fracture through the still open more lateral physis and through the epiphysis. So the name of this fracture is Tilo fracture. Now, so we were doing Salter-Harris type 2, Salter-Harris type 3. Now we are seeing a very blatant Salter-Harris type 4 fracture in which you have a vertical fracture through the epiphysis. It goes through the growth plate and nexus obliquely through the metaphysis. And here we have this fracture that goes through the fibula as well, but it goes through the metaphysis, growth plate, epiphysis, metaphysis, growth plate, epiphysis. It goes all the way. And in the distal tibia, this fracture is called a triplane fracture. Now we did the limb, the most common injuries, and now let's talk about the most missed lesions because it's something that haunts us radiologists quite a bit. So one that is pretty frequent, especially if you're just focusing on like proximal femur or very blatant fractures of the hip, is the acetabular hip. And whenever you want to assess the acetabulum, you have the help of the Judet views. So Judet views are basically you putting up one hip or the other. So this is the right hip up. This is the left hip up, and you see that it shows you different aspects of the acetabulum that you don't necessarily see very clearly on the frontal view, which would be the standard view you get initially. And in the Judet view, it can actually help you. In here, it's not very obvious that there is a fracture. The patient came after trauma. She's complaining of pain in the right hip, and it's not very obvious that there is a fracture. There is no apparent fracture line. However, whenever you obtain the Judet view, you see it much more clearly. There is a fracture through the posterior aspect or posterior column of the acetabulum. And you get the CT because the CT is the gold standard for acetabular fractures. And lo and behold, you definitely have that fracture through the posterior column of the acetabulum on the right. Now, it's not only like acetabular fractures, we also have lots of avulsion fractures that we can miss, especially if we're not paying attention. Some are very subtle, some are very small pieces. Avulsion fractures tend to happen whenever you have a very strong tendinous attachment into different bony protuberances, which is where the tendons attach. And whenever you have this pretty strong and sudden movement from that tendon, you could have an avulsion injury. It could be from trauma, could be from overtraining. We're going to see some of these examples. So we have different types of avulsion fractures in the hips. I wanted just to show you the most common ones. So the most common avulsion fracture of the hip is the ischial spine from the hamstrings. But we also have avulsion fractures of the anterior superior iliac spine and the anterior inferior iliac spine. This is the avulsion fracture of the ischial tuberosity seen on CT. I wanted to kind of show you some of the cases, but also a diagram which is going to make that much more easy to understand what's happening around. So here is the different tendinous insertions on the hip. In the iliac crest, we have the abdominal muscles attaching over here. Is not a very common site of injury, but it can happen. As I told you, the anterior superior iliac spine, which is where the sartorius inserts, and the anterior inferior iliac spine, which is where the rectus femoris insert, are part of the most common injuries, along with the ischial tuberosity, which is where the hamstring insert. The ischial tuberosity one, we see it very commonly with young adolescents playing soccer or rugby or whatever kind of like makes them cross their lower limb to the other side to kick a ball or do any type of activity similar to that. There's also the attachment of the iliopsoas into the lesser trochanter. This is a type of injury that we would tend to see on older ladies, perhaps with some osteoporosis. So we tend to see that, and this is the superior corner of the pubic symphysis, which is where the rectus abdominis attaches. Now, there are also avulsion injuries in the knee, and in this case, we have different things showing us different types of injuries. So we have this lateral femoral notch or deep sulcus sign in the femur, which is whenever we have this type of finding, it should make us think about this is a intra-articular fracture, and it's something that will require more evaluation with MRI or CT. In this case, we have these fragments in the intercondylar notch, which we usually see with the lesions of the PCL. In here we have the sulcus sign, and this sulcus sign and the arcuate piece. This is an avulsion injury that sits above the fibula. And here we have, again, an avulsion injury in the intercondylar notch. Here, aside from the fragment here in the intercondylar notch, I wanted to show you this very small piece of bone. This is another avulsion injury. It's called a second fracture, and is tightly associated with ACL injury. So in here, this was a patient that had quite extensive injury to the knee, even if in the radiograph it's not particularly evident. So both the ACL and PCL were out in this patient. Now here, this is the tibial tuberosity. This is an avulsion of the tibial tuberosity by the patellar tendon. And it's something that we can see either traumatic, or we can see in many cases by repetitive movements like jumping in like adolescent boys, basketball players, stuff like that. There is an avulsion of a very well-developed patellar tendon that kind of like takes off the tibial tuberosity. This is another example of that kind of like fragment in the posterior aspect of the like in the intercondylar region. This is a PCL injury, and in here we have this avulsion injury from the medial collateral ligament complex injury and avulsion. Now, we analyzed the ankle before. We mentioned that the lateral views of the ankle were very important. We want to also assess the posterior aspect of the distal tibia. However, something I didn't mention before, because I wanted to kind of like talk about it at this point, is that the lateral aspect of the ankle always needs to include the base of the fifth metatarsal. Because many times, whenever we have an injury, in this case fractures of the head of the fifth metatarsal, we can have this referred pain to the ankle area much more than the midfoot area. And we shouldn't be missing this kind of fractures, this kind of injuries. So this is a fifth metatarsal head fracture. Now, in this case, we have what we call a Lisfranc injury. Lisfranc is basically the joint or the place where the metatarsals get together with the tarsal bones. So whenever there is an injury here, it's actually pretty easy for it to complicate. You tend to see this in younger athletes, and whenever that's the case, you want to inform that to surgeons because it's something that they would definitely operate on sooner rather than later. And in the case of Lisfranc, so you have quite a quantity of different ligamentous structures here trying to put this all together. So whenever you have an injury, you tend to get like a series of injuries that come with it. So in this case, we have widening of the space here of the Lisfranc joint, and we have what we would call a homolateral. Like this homolateral, we're going to the same side, like all the metatarsal are dislocating to the same side, so they're not creating a joint with their different tarsal bones that they should be kind of like joining. Instead, they're going all towards the same side. But you could also have a divergent Lisfranc in which the first metatarsal goes in one direction, so usually to the middle, and the rest kind of like just go to the lateral aspect of the foot. This is how you would see a Lisfranc injury in the lateral aspect if that was kind of like the direction of the dislocation. So it's basically a detachment from the metatarsals from the tarsal region. So pretty unstable kind of injuries, and definitely very important to identify. And this is where I get to the end of what I had prepared, and I give space for whoever has some questions.
Thank you very much. I think this was a very insightful, detailed, and very clear presentation that you kind of walked us through. It was at just the right speed. So, yes, are there any questions from the audience? I'll also put this in the chat. Okay, you get some compliments. Well done. Brilliant and
Thank
concise.
you.
That's nice. Thank you. Okay, maybe there's some questions coming in. Actually, my background is in MRI imaging, so I'm not a clinician. I rather work on this technical side. So maybe I can ask that type of question because I look at a lot of
Sure.
knee images
Yes.
in MRI scans, like, and maybe, I mean, I don't know, maybe clinically that's not so relevant, but like, when do you decide for all these, or like roughly many of these procedures to do an MRI, and like when not? I mean, maybe that's a trivial question, but not to me.
No. That's a fair question. It's actually a question that sometimes imply also some sort of ethics on how much resources you want to spend in a single case. And that's where kind of like your clinical like background and how comfortable you are with the findings you already have with like a single technique, be it radiograph or CT. Many times, and I think nowadays more than ever, everybody and every system is pushing for much more specialized type of imaging, just to be sure. It's kind of like the main reason, just to be sure.
Yeah.
I think we need to balance it a little bit. I think whenever you're not sure and you think that the next available technique, be it CT, MRI, is going to really help in the diagnosis and is going to actually change the management, because many times it does, then I'm very happy to go all the way with whatever we have available. However, many times I think it's pretty clear from the beginning what the injury is, and there are certain injuries that are very well described with X-ray or with CT, in which probably MRI in these cases tends to be more redundant. So it's
yeah, I mean, makes a lot of sense. I mean, I guess you're right, and it's also so much faster. So, yeah, I mean, makes
yeah.
sense everything you say, I think.
But it's true that MRI is actually it's pretty big, especially in musculoskeletal radiology. We have so many structures that we need to assess aside from bones that we rely heavily on MRI and the different sequences.
But I guess to do this quick first check, as you say, it's much faster, I guess, to just do that. So
Yes.
we do have another question on if you could elaborate more about the Tilloch's fracture and triplane fracture.
Yes, of course. So let me just kind of like get out from here. There you go. Are you still
We don't see
seeing
the screen
anything?
now. Now we just see
Okay.
your desktop.
So let me go back to that. Now?
No, I'm sorry. It just
Do you see it?
no,
Yes? No?
no. Yeah, now we see it. Yes, there it is.
Okay, got it. So let's go back to let's do the triplane, which we have here, and then we can do the TILO. So the triplane or triplanar fractures are fractures specifically of the distal tibia, right? So here we have the proximal tibia. We cannot call this a triplane fracture. It's a specific of the distal tibia, and is somewhat like happens in a tilo fracture, is that there is a physiological closure of the physis or the physial plate in the medial aspect of the distal tibia. And the lateral aspect remains open for some time. So we have adolescents and they're kind of like starting to close their physis, and it closes from medial to lateral. So in that time in which the medial aspect actually closed, but the lateral aspect still open, if you have an injury, then this open physis in the lateral aspect is very prone to this type of fracture, this triplane fracture. So what you see is a vertical fracture through the epiphysis. So you have a vertical fracture through the epiphysis. This is the epiphysis, physis, metaphysis. So epiphysis, vertical fracture. You have a fracture through that open aspect of the tibial physis, and an oblique fracture through the metaphysis. So you get an oblique fracture to the metaphysis, you get the fracture through the open aspect of the physis, and you get a vertical fracture through the epiphysis. So this is what we call a triplane or triplanar fracture. And the tilo fracture, let me see if we're here. Here. And the tilo fracture is pretty much the same. It's just a different, there are variable amounts of displacement, and we don't have that metaphyseal aspect. So one would be a Salter-Harris type 3, which is this one, the tilo fracture. So you have a vertical fracture through the epiphysis and a fracture through that open aspect of the physis that is in the lateral aspect. So you know it's lateral because the fibula is on the lateral aspect. So lateral aspect, you see that it's open. This is wide open. This is where the physis already started closing in this adolescent, and you have a fracture through that physis and vertical through the epiphysis. So a T-low fracture. The triplane fracture would be a T-low also with a metaphyseal component, so it makes it a Salter-Harris type 4.
Okay, thanks a lot. There is also another question in the chat that was on what is the difference between a Tilo and a Salter type 2 fractures?
Okay. So a T-low is actually a Salter-Harris type 3 because the type 2 is actually just through the physis and the metaphysis only. So physis, metaphysis only. So you don't see it here. Physis through the epiphysis is a type 3. So type 2, physis, metaphysis. Type 3, physis, epiphysis. And a type 4 is through the plate, metaphysis, physis, epiphysis.
Okay, very clear. Thanks a lot.
Of course.
All right. Are there any more questions? You can also raise your hands. Yeah, and in the meantime, maybe while you're still thinking, a quick reminder to maybe quickly fill out our survey if you can, to give some feedback on our seminar. And also all these recordings will be on our YouTube channel. So if you would like to watch it back. All right.
Nice. Maybe it was very clear.
I think it was very clear. Yes. I mean, I learned a lot. Um, yes, unfortunately, I cannot ask like very deep clinical questions in this case, but for me, it was very clear, and I really learned a lot about these fractures and what can happen. I
I
guess
know
that
I could have made it more interesting for you if I went deep into MR, I guess.
no. For me personally, it's very interesting to actually see all these cases. I mean, for me, it is like, oh, where could we apply some MRI techniques, of course. So it is very important actually to learn this part. So no, it was excellent. I think that's very clear. So yeah, thanks a lot. So I guess if there's no further
Thank you.
questions, that's it for today. There were many participants, and I guess there will be many more online watching back.
Nice.
There will be also a seminar next month. So let me quickly look up who that's going to be. Yes. So next month there will be Sheila Wa, probably presenting on neurology and ASL. So of course we are happy to see you all back, and we thank you very much again, Carolina, for this very nice, clear and educational
Thank you.
presentation, and for your time on presenting and participating in the seminar. And yes, I thank
Absolutely.
you everyone for coming.
Thank you. Thank you. Thank you for having me.
Yes, have a good time. Have a nice
You
evening, I
too.
guess. Okay, bye everyone.
Bye. Bye.